Hi, my name is Khalid Sharif. I'm a consultant orthopedic surgeon with an interest in sports surgery. I want to do an educational video today on hamstring injuries, and that's partly because my son Abraham is a very good long jumper, and his colleagues are always consulting me about sports injuries and very often their hamstring injuries. So the hamstrings are four muscles at the back of the thigh. The biceps, long head and short head on the outside, the semimembranoses and semitendinoses on the inside. The three of the hamstring muscles, apart from the short head, originate from the ischial tuberosity, and the short head actually originates from the linea aspera of the femur. Their function is to extend the hip and flex the knee. And who gets these injuries? So they get people from 16 to 25, 10 years old. They tend to be the ones that get them most. And it's athletes, usually sprinters, jumpers, sometimes swimmers, and it tends to happen in the late swing phase of the sprint, when you flex the hip with an extended knee, that you get the injury. So what are the predisposing factors to them? So it's weak muscles. When there's an imbalance between the strength of the hamstring and the quadriceps, the poor flexibility, poor warm-up, fatigued muscles, and those athletes that have had ACL surgery or have got back problems are more prone to get them. The presentation is important, and I want to stress the difference between a sprain and a tear, and that very often worries athletes. The difference is a sprain, and I've seen them on the track, they get sudden pain at the back of the thigh. The sprained ones, and both of them will get this pain, but the sprained ones will get pain, no pop, no hematoma. They can usually walk. They may not be able to continue with their athletic activities, but there's no reduction in the strength of flexion in the knee. And I use a test which is very useful, which is the plank test. If they can lift their thigh in a plank position, it's usually a sprain and not a tear. The diagnosis, I get an x-ray because I want to differentiate if there's an avulsion fracture in the bone here. But otherwise, the x-ray doesn't give you very much more information. MRI is the gold standard because it gives you the site and the degree of the tear. Ultrasound is also useful, but it's operator dependent, and it's useful to give a PRP guided injection. And before I forget, I want to talk a bit about PRP because the literature here is very diverse. Some show that the pain is less after you give a PRP injection and they go back to their original sporting activity quicker. Some shows no difference to placebo. My view is that if there's no definite indication for surgical intervention and physiotherapy doesn't work or is taking time, then there's no harm in giving a PRP injection because it's minimally invasive and it's not that expensive. Now, how do we prevent these injuries? And I refer you here to my colleague John Shepherd, who's an excellent athletic coach. He trains my son, and he's got a video channel about how to train, how to warm up, and I will try and leave a link at the end for his YouTube channel. It's brilliant. But generally, you have to get a good warm-up, and that includes dynamic stretching exercises like leg swings and lunges, balanced strengthening exercise between the quadriceps and the hamstring, and that includes Nordic curls, leg curls, deadlifts. Also, some core strengthening exercises like planks, bridges, side leg raises, and post warm-up stretches are very important. A gradual workup into the athletic activity is very important. Having adequate intervals between these activities is very important. Hydration, nutrition, it all plays a role. The equipment you use, your footwear, the surface you train on mustn't be slippery. And also you have to listen to your body really. If you're not flexible that day, if it's painful, don't do the full workup. I want to come to the treatment. For the chronic ones, if physiotherapy and exercises doesn't work, painkillers, then we usually resort to surgery. And these patients, they tend to need debridement and reattachment of the tendon. Regarding the sprains, they will recover very quickly. All they need is some painkillers, maybe some local ice, and a period of rest, maybe 24 to 48 hours, but no more than that really. And then they have to go back into their stretching exercises, strengthening exercises, and their full athletic activity. Regarding the surgical treatment, and I want to stress here on the timing of the surgery, it has been shown that the earlier you do the surgery, the better the outcome, the less the complications, the quicker the return to sporting activities. I would recommend within 4 to 6 weeks, really. There has been some papers showing that there's a difference between the ones that have had it less than 2 months after the injury compared to ones that have had it some 11 months after the injury, and there's a big difference in the outcome. So the treatment is guided by the classification. There are many classifications for these hamstring injuries, but the main two that I want to mention are the Woods classification and the British Athletic classification. The Wood classification goes from 1 to 6. 1 is an avulsion, a fracture of the tuberosity that happens in children. Then we have the 2, 3 is a partial injury, and 4, 5, and 6 are complete tears. The British Athletic classification goes from 0 to 4. So 0 is a sprain and you find nothing on the MRI or the ultrasound. The 1 is a small tear, 2 is a moderate tear, 3 is a large tear, and these are all partial. So 2, 3, and so 1, 2, and 3 are partial. 4 is a complete tear. And there are also sub-classifications in the British classification into A, B, and C, according to whether it's myofascial in where the injury is, if it's myofascial, musculotendinous, or tendinous. The myofascial ones are the good prognosis ones. They're sort of A. The musculotendinous ones and the tendinous ones are poor prognosis, because the blood supply is not so good. They don't tend to scar so well. They take much longer to heal, and the recurrence rate is much higher. It's about 50%. There's also the difference between 1, 2, 3, and 4 also depends on the cross area of the tendon that's affected. So 1 is less than 10%, 2 is 10 to 50%, 3 is more than 50%, and 4 is a full tear. And the length of the tear is also, it goes from 1 is less than 1 centimeter, 2 is 1 to 5, 3 is more than 5 centimeter, and 4 is a complete tear with a full retraction. So how do we treat them? Usually we try some physiotherapy in the beginning and some exercises, and then with the full tears we put them in a prone position, and it's a transverse incision at the buttock crease. We have to be careful about the posterior cutaneous nerve of the thigh, and then dissect the sciatic nerve, which is very close actually to the origin of the hamstrings. And sometimes I've seen cases where they've injured they've torn the hamstring, and they come with pins and needles because of the hematoma or tethering of the nerve, or even they can get a foot drop. So after that, you debride the area and you shorten the tendon very little, minimal shortening, because you don't want to reduce the length of the tendon. So it's a minimal debridement, and then you reattach it via suture anchors. The recovery period afterwards, I would say about 4 months for return to full sporting activities. It starts with first 6 weeks. Usually we put them into a brace locked at 0, and we don't allow them to flex their hips, and we increase that by 30 degrees every week. And then they're also they're avoiding walking on that side. They may use crutches for the first 6 weeks, and then they go into stretching exercises, range of movement exercises, and then into the strengthening exercises. And they're only allowed to go back to the sport when the two sides are symmetrical in strength. Generally, the ones that I recommend surgery are the full thickness tears, the 3 tendon tears. And they used to talk about the partial thickness if it is less than 2 centimeters, more than 2 centimeters. That's obsolete, really. You have to take many factors into consideration. How high grade is that athlete, the grade of the tear, whether there is any nerve involvement or not, and see basically what you have to consent the patient properly. But the full thickness tear in an active athlete needs surgery. The high grade tears especially in a high grade athlete, needs surgery. Otherwise, especially for the myofascial injuries, 80% respond to conservative treatment of physiotherapy if they are not of a high grade. I hope that's useful. Thank you very much.